All right, here we go. Hello, everyone, and thank you for watching this presentation on the best rehab codes. This is part two. We did part one a couple of months ago, and we have some new updated information to share. That's why we're calling it part two. There's no audio taping or videotaping allowed. Any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information contained in this presentation is for educational purposes. It's not intended to be a substitute for your thorough clinical decision making. It's not intended to be legal advice. Target coding does not provide legal services. CPT is a registered trademark of the AMA. Every attempt has been made certain that the information in this presentation is 100% accurate. However, it's not guaranteed. Just a little bit about myself before we get going here. My name is Dr. Marty Kotler. I'm a chiropractor. I'm a certified professional compliance officer. I'm a certified billing and coding specialist. That's what those initials are after my name. Target coding specializes in compliance as it relates to Medicare, HIPAA, billing, coding, documentation. We also help doctors nationwide with record keeping, putting together compliant cash plans, preventing dual fee schedules, treatment plans, care plans. I've written many training manuals on billing, coding, and documentation for chiropractors, physical therapists, and acupuncturists. I write articles to numerous publications and journals like Chiropractic Economics, Dynamic Chiropractic, The American Chiropractor, the American Academy of Professional Coders magazine, and for many state association newsletters throughout the country. Plus, I'm a guest speaker at many state association conventions throughout the country. So let's begin with who can provide rehab services. Well, let's start off with a couple of categories. Qualified healthcare professionals can definitely provide rehab services. Let's dig deep into what is considered or who is considered a qualified healthcare professional. Well, a qualified healthcare professional is an individual who's qualified by education, training, who is licensed to provide services and can independently report that service, meaning this is a person that can bill an insurance company. A QHP, can have his or her name on a claim form and submit the claim to an insurance company. So QHPs include chiropractors, medical doctors, nurse practitioners. And the next category I want to share with you are clinical staff members. A clinical staff member is a person who works under the supervision of a QHP, like a chiropractor or a physical therapist, or other qualified healthcare professional who is allowed by law and regulation and state scope of practice to perform that service. However, they cannot individually report that service. Good example, your CA, chiropractic assistant in the office, performing a service with the doctor on site, sure, no problem. And not in all states, but in many states. Now, if the doctor's not in the office and your CA is performing a service, your CA cannot have his or her name on the claim. Insurance companies don't pay for services provided by CAs without the provider in the office, or in some states, they don't pay for a CA doing the service at all. So QHPs, qualified healthcare professionals, include MDs, DOs, DCs, physical therapists, nurse practitioners, physician assistants, massage therapists in some states can perform services and bill insurance directly, acupuncturists. Clinical staff, we're talking about CAs and PTAs and nurses and athletic trainers, nutritionists, medical assistants. Supervision rules. Well, there are three types of supervision. Personal, direct, and general. Personal supervision means you are in the room with your staff member. Direct supervision means you're in the office, but not necessarily in that room with the patient and the staff member. General supervision means you're not even on site. You have staff members performing the service, but you're not on site. Most states don't allow chiropractors to do services or bill for services when the doctor's not on site. Now, Medicare, as far as paying for rehab services, Medicare says the PT needs to be on site when the PTA is performing the service. That's direct supervision. So Medicare says QHP needs to be on site, like a PT, when a clinical staff member, like a PTA, is performing the service. Now, state rules can be complex. Sometimes they're hard to find. You want to go contact your state board and find out who can provide the services. It could be difficult. It could conflict with federal rules and regulations and payers' coverage policies. See, within your scope of practice, you might be able to have a staff member perform the service, but then you go ahead and find out that it's not even a covered service in the plan. So supervision rules can vary greatly from state to state, and they're always changing. In some states, chiropractic assistants are not allowed to perform any type of rehab services. There are some states where chiropractic assistants cannot even put a hot pack on a patient. So check with your state board on the staff members who you can employ and what services they're allowed to perform. In some states, chiropractors are not allowed to employ physical therapists. So if you employ a PT in a state where you're not allowed to, you see how you could be submitting false claims, and that could become a big problem. So check with all the health plans on supervision requirements prior to billing. Inquire as to who needs to be on premises when the procedures are performed. Okay, so now we're going to get right into the best rehab codes. They're also known as therapeutic procedures. So therapeutic procedures is a manner of effecting change through the application of clinical skills and or services that attempt to improve function. So the key terms there are application of clinical skills and improving function. So when you're providing a therapeutic procedure, and I ask you, what clinical skills are you applying? Make sure you have a good answer. If you're not applying any clinical skills, then it's not a billable service. If you have a patient doing abdominal crunches and you're not applying any clinical skill, then it's not a billable service. If you have a patient just walking on a treadmill or riding a stationary bike and you're not applying any clinical skills, it shouldn't be billed to insurance. So I'll give you examples of what application of clinical skills mean and what they are in a few minutes, but that's something you should definitely be thinking about if you're billing insurance. What clinical skills are you or a staff member applying while the patient is performing the rehab service? One-on-one contact is required. It doesn't have to be constant. You could be with a patient one-on-one for 5 minutes and you could walk away for a few minutes and then you can come back. But one-on-one is required. One or more areas, each 15 minutes, meaning these are time-based codes. So if you do a rehab procedure for, let's say, 15 minutes, you bill 1 unit. If you do it for 30 minutes, regardless of how many areas you do it on, then you can bill 2 units. So let's begin with our first procedure and CPT code 97110, therapeutic exercises. It's used to develop strength, endurance, range of motion, and flexibility. That's what that acronym is there on your screen, SERF, S-E-R-F. S stands for strength, E, endurance, R, range of motion, F, flexibility. So you need to be accomplishing at least one of those parameters. So Mrs. Jones comes in with neck pain and low back stiffness, and you do an exam and she has restricted motion. So your intent could be to increase range of motion, the R in the SERF. That's fine. So if you're going to bill 97110 in order to increase range of motion, if that's your intended goal, then what should the patient have a lack of when they come in? Yeah, you got it, range of motion. So your history, you have to create that little breadcrumb trail For every service you provide, not only rehab procedures, but if you're going to bill for therapeutic exercises, the little breadcrumb trail I'm referring to is Mrs. Jones comes in with neck pain and neck stiffness. Okay, there we go. Well, there's neck pain and stiffness. There's our first little breadcrumb. Now you do an exam and you do, let's say, range of motion, and she has restricted motion in her neck. You find tenderness and tightness in her neck. You find subluxations in her neck, and maybe some muscle tightness or hypertonicity. That is your next breadcrumb. And then your intent is to increase range of motion. See, if you're billing 97110 and your history doesn't show any restriction in motion, your exam shows normal range of motion, or you didn't do range of motion at all, that's where you'll have a problem. It's an active procedure. Active procedure means the patient needs to be doing the service. Passive means the patient is just lying on the table or on the floor doing nothing, and you're performing the service on them. Active means they're doing the service. Your documentation must make sense. Again, if you're going to do therapeutic exercises on a patient, let's say to increase strength and flexibility, what should the patient have a lack of when they come in? Yes, strength and flexibility. So it's an active procedure. Here are multiple examples of active procedures using tubes, balls, bands, weights. You could even use tubes and balls simultaneously. They could be against the wall. Patients could be lying on the floor doing exercises, but they must be doing the service, and you're overseeing. The clinical skills you're applying is, see the patient in the top right corner lifting weights. You or a staff member, assuming it's okay in your state for a CA to be overseeing the service, are watching the patient, making sure the patient isn't going to hurt themselves. You're going to give verbal cues. Maybe you're going to put your hands on the patient, tell them to slow down or go faster, and you're giving them assistance, making sure they're okay. Now, after they do it okay, let's say after, a few visits, they're doing it okay, and they can do it at home without your assistance, then you shouldn't be billing for it anymore in your practice. So here's a few examples of active procedures. Now, some of you on the line are already doing rehab. You're up and running, and you're just checking in here to make sure you're doing things right. And some of you are just thinking about incorporating rehab. I would say about 30% of the doctors that I speak with do not do any rehab at all. They are straight adjusters, so to speak, or they'll do an adjustment and maybe some mechanical traction or some CBP or some Pedibond, and basically it's an adjustment. And then you're listening to this presentation because you're thinking about, I would like to incorporate some rehab into my practice. If you want to start with very, very low-tech rehab, I recommend you contact foot levelers and get the Nexus and the Baxis. That's what you see on your screen. It's so simple. With the Nexus, that's what it's called, you would just attach it to a wall or a door. You could be up and running in 5 minutes if you wanted to incorporate some rehab. You're thinking about doing it, you're not sure. Hey, you want to start with some really good neck isometric exercises? There really aren't too many devices that I see that could be isometric in nature. So here's the Nexus, and then Foot Levelers also sells the Baxis rehab device. Many people think Foot Levelers only sells orthotics. They actually sell pretty decent rehab equipment, and they also sell fantastic pillows. So here are some other active procedures. Patient, you don't even need, when I first started billing 97110, I didn't have equipment. I had patients lying on the floor doing abdominal exercises, core exercises, bringing their knee up to the chest and doing some back extension. So you don't even need to have equipment. But yes, you should have some balls, bands, tubes, but it's an active procedure. Next is neuromuscular reeducation. That's 97112. This is used to improve movement, balance, coordination, kinesthetic sense, posture, proprioception. It's reasonable for impairments which affect the body's neuromuscular system. Examples include PNF, that's proprioceptive neuromuscular facilitation, Feldenkrais method, balance boards, BAPS boards. Most insurance companies are okay if you use this for typical musculoskeletal problems. There are a few insurance companies that say, no way, we're not going to pay for neuromuscular re-education unless the patient has had a stroke or, a multiple sclerosis, some sort of advanced degenerative neuromusculoskeletal condition. So just check with your plans before you bill any of these codes. Next is manual therapy. That's 97140, 97140, manual therapy techniques. This could be a combination of one or more of the following: soft tissue mobilization, joint mobilization, manipulation, manual lymphatic drainage, myofascial release, non-injectable trigger point therapy, manual traction. It could be one or more of those. You may have a patient lying on the table where you do a few minutes of joint mobilization, a few minutes of manual traction, a few minutes of myofascial release. That's fine. Doesn't have to be one. Now, what I don't like that's built into the definition of this code is manipulation. Why that's in there, I don't like. Well, I don't get either, but you'll see on this list here on the screen, it says CCI edit. The National Correct Coding Initiative edits prevents insurance companies or helps insurance companies pay for two services that are considered, similar in nature. So they put a bundling edit or a CCI edit on it. So unfortunately for this code, there's an edit with the chiropractic manipulation, the chiropractic spinal adjustments, as the AMA calls it, CMT, chiropractic manipulative treatment to the spine. So if you're going to do this, well, here, this just doesn't make sense to me, but I'll give you the scenario so it hits home. Mr. Evans comes into your office with neck pain and neck stiffness, and you want to do some myofascial release or some soft tissue mobilization. And after you do that for a few minutes, you would like to adjust, maybe C5, C6, C1, C2. Well, according to the CCI edits, no good. It's a duplication of service. And I think one of the reasons why, and to me that's silly, but I think one of the reasons why that happens is because the word manipulation is built into this code. You're not doing a manipulation for 97140. You're doing a chiropractic adjustment. How is that the same thing as doing some myofascial release or some manual traction or manual lymphatic drainage? I don't get it, but I don't make the rules. I just share them with you. So just a heads up, there's a CCI edit on this code. It's not supposed to be done in the same anatomic site as the chiropractic adjustment. If it is, you won't get paid for the 97140. So let's say the patient has two problems. Mr. Evans has neck problems and lower back problems, and you want to do some myofascial release or joint mobilization on the neck. Go ahead and do that. And now you want to do a chiropractic adjustment on the lumbar region, let's say L4, L5. You're okay there. So 98940 for the lumbar region, 97140 with the 5-9 modifier. Because it's in a separate site than the lumbar region, you're doing the manual therapy on the cervical region. So that's why the 5-9 modifier would need to be appended. Without the 5-9, they'll bundle both of the codes together and only pay you for the adjustment. And you should have a separate and distinct diagnosis. And this is what I consider passive care. Myofascial release is passive care. The patient is just lying on the table and you're doing the work. You're stretching the shortened connective tissue. So if you're just doing a passive type of service, that's not considered 97110 therapeutic exercises. So if you're doing passive type of deep soft tissue stretching, don't call that 97110. Now, something came up recently at the beginning of this year with Medicare billing. You should be adding the GP modifier to your Medicare claims. If you don't, it'll come back, patient may not be billed. Now, this is a Medicare patient that comes in with a secondary insurance that may pick up the rehab services. So if you're billing for those and you've been getting paid by the secondary and Medicare, the primary has been processing it properly, then all good. If for some reason, out of the clear blue sky, starting January 1st of this year, you're seeing your Medicare claims come back for the rehab codes as contractual obligation, patient may not be billed, and now it's not even getting to the secondary and the patient can't be billed, it's probably because your Medicare carrier now requires the GP modifier on the therapy codes. Next is therapeutic activities, 97530. These should be performed to improve functional performance. A lot of people call this code the ING code because whatever you're doing, it should relate to helping the patient with bending, lifting, carrying, reaching, throwing. You need to restore function in a progressive manner. It's a multi-parameter code, and it must relate to an ADL. Example, increase flexibility of the quadratus lumborum muscles while activating and stretching the hamstring muscles to improve the patient's capacity for walking and standing. This CPT code has the highest RVU out of the rehab codes that I've mentioned. Why does it have the highest RVU, meaning it pays the most? It's because you have to do more. It's a multi-parameter code, and you have to relate it to an activity of daily living. Different than 97110, right? And these codes are all time-based. There are two schools of thought. There's total time versus rule of 8, total time. You have to total up all the time you perform doing all the time-based codes and then determine how many units or codes to bill. So 8 to 22 minutes is 1 unit, 23 to 37 is 2 units, and on and on. So here's the example I like to give. 97140 for 23 minutes. Your first thought process might be, okay, I can bill that for 2 units, right? And then you do 23 minutes of 97110. Well, I could do that for another. I could bill that for another 2 units, right? No, if you're using the total time method, what is that total? 46 minutes. 46 minutes, you could only bill 3 units. Can't bill 4. Now, if you do 30 minutes of 97140 and then follow it with 23 minutes of 110, what is that total? That totals 53 minutes. Aha, now you can bill 2 units of each code. Now, some insurance companies, you'll have to check, may follow the rule of 8, which means 8 minutes of 140, and then follow that with 8 minutes of 110, and that totals 16 minutes, but you could bill both codes if the insurance company follows the rule of 8. But if you're billing, let's say, United Healthcare Optum for 8 minutes of 140 and then 8 minutes of 110, totaling 16 minutes, you'd only be able to bill one code because 16 minutes falls in between 8 and 22. Now, you want to be able to justify the services you're providing. So if you're going to do, let's say, therapeutic exercises on, let's say, a patient comes in with some sort of sacroiliac joint problem, sacroiliac subluxation, sacroiliac sprain, sacroiliitis, and you're going to have the patient do some rehab exercises to fix this diagnosis. Well, make sure you have the proper justification. So if you're billing an insurance company and they contact you, let's say a case manager, or if it's a malpractice case, and they go, hey, Dr. Kotler, we see you're billing sacroiliac joint problems on this patient. Can you tell me, how did you come up with that? Well, the patient had tenderness in the joint, or maybe both SI joints. Yeoman's, Ganslin's was done. Those are the gold standard ortho tests. Palpation, tenderness, subluxation, hypertonicity, took x-rays to rule out SI joints. So you want to have the justification for the codes that you choose. Let's say you're going to diagnose a patient with cervical radiculopathy, and now you're questioned, well, how did you come up with that? Have a good answer. You see, you might do this. A patient comes in with low back pain and pain down the leg, and you just diagnose sciatica. You don't do any ortho, neuro, reflexes. You don't do anything. You just diagnose sciatica. It can come back to bite you in the butt if you don't have the justification. You might not get paid. If this is a state board issue or a malpractice case, you'll lose. So you're going to diagnose a patient with cervical radiculopathy, and your notes should say the patient has pain in the neck radiating into the arm. You did a little Jackson compression, Valsalva, the shoulder abduction. You did a couple of ortho-neuro tests. You checked for myotomal weakness. You checked reflexes. You know, if a patient comes in with just mild low back pain or mild neck pain, do you have to do reflexes? Do you have to take out your pinwheel and check for dermatomal and problems? Probably not. You still might want to do it, but I guess you don't have to if you don't think it's clinically indicated. But with cervical radiculopathy, if that's your diagnosis, yeah, you should check for reflexes and dermatome changes and range of motion. Oh, so this is an excerpt of a book that I recommend every chiropractic practice have. This book has a whole bunch of diagnosis codes and the ortho, neuro, and chiro tests to support that code. For example, on this page here, you look at the bottom, cervical brachial syndrome. It's pretty common in chiropractic. So if you're going to diagnose the patient with M53.1, that's cervical brachial syndrome, and you're going to do some rehab services, like therapeutic exercises or manual therapy, which fit beautifully with this diagnosis code, do Wright's, Atson's, again, check for reflexes, check a few, posture and subluxation findings. Oh, here's a little update. We're talking about diagnosis codes. Don't use M4806 anymore. If you're going to use lumbar stenosis, it's either with neurogenic claudication or without neurogenic claudication. It's a little bit here on modalities. This webinar is on the best rehab codes, but I thought I'd throw in here a little bit about modalities. These are the supervised modalities. These do not require one-on-one patient contact. They're not time-based. The most common ones are traction and unattended electrical stim. That's 97012, mechanical traction, and unattended electrical stim is 97014, or some carriers prefer the G code G0283. Then we have constant attendance modalities. This is the application of a modality that does require one-on-one patient contact. You see, with modalities, it's the machine that you buy that dictates the code. If you're going to bill for ultrasound, which is the most common constant attendance modality you see on this list, ultrasound, you have to have an ultrasound machine. If you're going to bill for traction, you have to have a traction machine, right? So it's the machine, the device, the gizmo that you buy that dictates modalities. It's not the case with rehab codes. As I mentioned earlier, you could bill for rehab codes and you don't even need any equipment. So there's one of the differences. Some have used vibration therapy. Careful with this. There's no code for vibration therapy. And there's dry hydrotherapy. Careful with this one. Basically, you could use heat. I don't think you could use any other code for dry hydrotherapy. Careful with some handheld devices. Some insurance companies say, we don't pay for handheld instruments. So just a little heads up on that. And you want to be as compliant as possible, right? That's what I hear all the time from doctors throughout the country. They come up to me after my seminars and webinars. They go, Dr. Kotler, I'd like you to help me. I want to make sure I'm doing everything right. Okay, well, part of making sure you're doing everything right is putting together a policy and procedure manual. Medicare requires it. Medicare policies and procedures are required. Medicare, if you see Medicare patients, you should have a billing and coding policy manual. Even if you don't see Medicare patients, you should have a billing and coding policy manual. The OIG oversees Medicare, so they want to make sure you're proactive and you're doing things right. Put together a policy manual. Even if you don't see Medicare patients, as I said, you should have policies and procedures. You should have regular staff trainings. You should conduct internal reviews of your records. Here's our little spreadsheet that we put together for the doctors we work with a compliance manual, and we use this spreadsheet for chiros, PTs, acupuncturists. It's not the same exact one, but it's a similar format where it's an open book test. You score yourself, you go down the list, you pull a few charts 2 or 3 times a year. It's not that outrageous. This should take probably, I don't know, maybe 5 hours a year, not a week, not a month, maybe we're talking about 5 hours per year to do some internal reviews. Here's a formal training log. If you say, yes, Dr. Kotler, we do staff trainings. Well, do you write them down? Oh, no. We just discuss them. No, write them down. Get a training log. If you see Medicare patients, you're supposed to put your name in the exclusions list, and hopefully it doesn't pop up. If it does, you're not allowed to see Medicare patients. If you were looking to hire this person, Douglas Godfrey, and he was going to be seeing Medicare patients in your practice, go to exclusions.oig.hhs.gov. You put his name in here, and boom, oh no, it pops up. You cannot employ him to treat Medicare patients. So read the coverage policies from the health plans you bill. Make sure that you understand when to bill rehab codes, how many times per week. Sometimes they will actually tell you in the policy how many times per week they recommend therapeutic exercises and therapeutic activities. Try to follow those policies as best you can. Now, if you don't want to follow the policies, you don't have to, but understand you won't get paid by insurance, and you could be violating your standard of practice in your state. So read the policies, review the policies with your staff, log the trainings into your policy and procedure manual. A policy and procedure manual helps prevent audits. It'll help you sleep better at night, and it could improve office efficiency. So get good with your rehab codes. Please check with all the carriers you bill prior to submitting claims. Can't guarantee that this information will guarantee payment from any insurance company or patient. Here's our contact information. We're going to get to questions in a couple of minutes. Here's our contact information, info@targetcoding.com, website targetcoding.com. Do me a favor. Go to Facebook, like us on Facebook, follow us on Twitter, follow us on Instagram, check us out on YouTube. Just type in the search Target Coding or my name, Marty Kotler, DC, and anybody that wants a compliance manual, if you follow us on Instagram, we are taking $100 off. So this is what we do here at Target Coding. We do seminars nationwide. We do webinars. We sell videos. We do on-site consulting. We have membership programs. We have hourly consulting. If you wanted to just go 1 hour at a time, that's fine. We sell a book of forms, letters, and templates. We sell a guidebook on the best chiropractic and ICD-10 codes, ICD-10 and CPT codes, to improve reimbursement. We offer HIPAA compliance programs. We offer Medicare policy and procedure manuals. So we do a lot here at Target Coding. This is the book that I was referring to, which I think every chiropractic practice in the country should have. It's the book on the best ICD-10 and CPT codes to improve reimbursement. It provides the clinical rationale for many of the most common diagnosis codes. It also provides a FAQ section, simple stuff like, what's the difference between a disc disorder and a disc displacement? Patient comes in with a herniated disc. Should you choose disc disorder or disc displacement? What's the difference between a fusion, swelling? These questions might seem pretty simple, but many doctors just don't know the answer. So, and that's okay. Don't be embarrassed. You could be in practice for, 10, 15 years. You might not know the difference between myalgia, myositis, and myofasciitis. You might not know the difference between idiopathic scoliosis and thoracogenic scoliosis. Maybe you don't know the difference between cervical brachial syndrome and cervical radiculitis. So we try and answer some of these mysteries, and we provide you with the diagnosis codes that pay for the most visits versus the ones that pay for the least amount of visits. We also provide you with a section on how to pair, like you pair wine and food. We show you how to pair your CPT codes and diagnosis codes. Plus, there's a whole section on these. We offer these cheat sheets. Quick glance, you could see which codes are long-term treatment codes versus short-term treatment codes. Those of you that employ PTs that do the rehab, we have a physical therapy webinar coming up on March 22nd. We go over the rehab codes. There's major changes that have occurred to the therapy cap this year, so you might want to check this webinar out. We're also doing an acupuncture webinar on March 29th. If you're interested in a compliance manual, let us know. The compliance manuals include personalized policies and procedures for your practice, training logs, the $75 rule, information on prompt pay discounts, opt-out rules, proper use of the ABN. We also offer HIPAA programs. Most offices are between 1 to 10 employees. So you get a cloud-based storage portal, you get a 3-ring binder, you get ongoing trainings, you can log in whenever you want and watch videos, get your staff trained. We help you track business associates. We give you all the HIPAA forms, logs, templates. There's our acupuncture billing and coding policy manual. There's our basic membership, $99 a month. It includes all of our live webinars. We do live webinars just about every week, and many of them include CE credits. Not this one, but our CE webinars are terrific, and if you're a basic member, it's included. You don't have to pay extra, and you can get, I think it's up to 17 CE credits a year with us. So I want to thank everybody for attending. Again, please like us on Facebook, follow us on Twitter and Instagram, and check us out on YouTube. So again, I want to thank everybody for attending. I hope you learned a lot.